So what do you think? Can you be so healthy that your labs look unhealthy? I put together a fun list of ways that you can school anyone who's going to reflexively treat a number on your labs. Here are 6 values that might look abnormal for healthy reasons, and how you can tell the difference. Let's run through liver enzymes, kidney function, a protein called sex hormone binding globulin, or SHBG, cholesterol, high estrogen in men, and elevated BMI. But first, I'm Dr. Alex Watson, and I get people ready. And by that, I mean I get them ready for cancer therapies, surgeries, and fitness-based competitions. In this case, I'm going to get you ready to deal with a healthcare professional who doesn't quite know their way around healthy labs for a healthy person. All right, let's get started with liver enzymes. So normally, when someone like me is going to look at the average person's labs, we consider ALT and AST the 2 most important liver enzymes we're trying to figure out about your health. Typically, as a general thumb, I look for 20 and 20, even well below the upper cutoff of 45-ish, somewhere in the 50s for ALT. And I want to make sure that they're about equal. And the reason why is that they're expressed in different amounts in different tissues in the body. And so when they're both kind of at that similar baseline, you know that nothing's really inflamed or breaking down or releasing these enzymes into the blood. And so you're at this kind of steady state level. There are a couple different patterns I'm looking for when I'm worried about certain diseases. So if your ALT is higher than AST, L I think of as liver, and that's going to strongly suggest some sort of hepatocyte, so liver cell injury. So whether it's a viral infection or exposure to some toxin, alcohol is a little different, so we'll get into that in a second. But typically, if you don't have some obvious acute exposure and the levels are only a little bit elevated, something like 50 and 25, 60 and 30, whatever it is, that's going to be most likely a case of metabolic associated steatotic liver disease, or in other words, fatty liver disease from metabolic causes. This is the most common cause of elevated ALT in the developed world, really, and used to be pretty rare, but now it's quite common. So when I see this ALT, I'm a little conservative in these cases where, again, if there's a disproportionate amount, I'm getting a little suspicious. If you're at a 2-to-1 ratio, it's pretty much a fairly good slam dunk here. If there's any sort of ratio, 1.2, 1.3 to 1 here, so something like 30 to 20 is going to be 1.5 to 1 between the ALT and AST, that's concerning to me. If you're at a 2-to-1 ratio already, that means something's almost certainly cooking in there and you want to get this addressed. When the AST is much higher than ALT, so reverse that one, that is going to be your typical alcoholic hepatitis. So you have alcohol-related inflammation of the liver, AST starts rising for a bunch of reasons that I'll get into for the handful of biochemistry nerds out there. But it's not typically one of those other causes. You don't see AST higher than ALT from an exclusively metabolic related cause. So for the biochemistry nerds here, the reason why your AST is higher than the ALT in alcohol related injuries is that the alcohol actually preferentially damages mitochondria. So you spill out this AST from that reason. And on the ALT side, you have a B6 deficiency related ALT decrease in synthesis. So you burn out your B6, you produce less ALT, and the mitochondria get all attacked and stuff, and then it causes the release of AST. So you get that inverse balance here that you would expect from other sort of acute toxicities and that kind of stuff. All right, back to the main thing. So in this case, if an equal elevation, it's tough to say what the exact cause is, whether it's an ischemic related, so decreased blood flow to the liver, causing release of these enzymes, or some other drug exposure, viral exposure, that may not be an acute kind of thing. But I kept seeing this pattern in healthy folks, myself included, where you get blood drawn and all of a sudden you see these random AST elevations and ALT elevations and realize that, well, what are these enzymes? What are they doing? They're helping to recycle amino acids that are breaking down for utilization in the liver and metabolic processes, things like that. Where else are those amino acids? Abundant in muscle tissue. So if you've had a hard workout within 24 hours, give or take, a blood test, you're going to be breaking down muscle tissue and spilling out the ALT and AST. So you're going to see this elevation in both of those. And that's why in a healthy person, you might see random elevations in liver enzymes. So if your doctor starts to sit you down and talk about your lifestyle, first reflect on your recent training and maybe ask for a retest. Here's one that I've ranted about many a time. Patients, YouTube videos, all the above. creatinine elevations. So if your creatinine is elevated normally, this implies that your kidneys are not filtering as well as they should, and so you're collecting this creatinine in your blood, and that is a cause of this creatinine elevation. So the typical interpretation is your creatinine goes up. It's because your kidney filtration went down, therefore you have some kidney problems, and you're collecting the stuff. Some non-immediate concerning reasons for raising this is going to be if you start on a medication that initially decreases filtration in the kidneys before everything kind of re-equilibrates, something like lisinopril, all the ACE inhibitors, or the sartans or angiotensin receptor blockers. Those will raise your creatinine because of the way that they change the perfusion, the blood flow to the kidney. Healthy stuff. Actually protects the kidney in the long run. If you're taking creatine, you are going to have more creatinine. Creatine breaks down to creatinine, so when you're taking the stuff long enough, you're going to have a buildup of creatinine just because more substrate, more product. That's the way it works. It's math. So in this case, I set my creatine right here. It's not usually an acute thing. So if you start taking creatine last week, get a blood test today, your creatinine probably won't go up. And if it does, research says it might be just coincidence. However, if you've been on for a while and your body's been able to build up its stores of creatine, well, then all the activities you're doing, you're going to be breaking that stuff down because you're utilizing it for its purpose of acting as what's called a phosphate donor. So essentially, it's an overdraft account, as I say, for metabolically active activities. When you burn through all the ATP, your tissues are your cellular machinery are looking for something else to use as energy so it can continue its normal processes. It finds creatine phosphate, hydrolyzes that phosphate group off there, gets the energy it needs, and there you go. In the process, creatinine rises, and it looks like your kidneys are doing worse, but in actuality, you just have more of the precursor. I typically see a rise of about 0.2 milligrams per deciliter. So if you're normally at a 0.8 for creatinine, and you go to 1.0, and an EGFR, so the glomerular I can't even say it. So the glomerular filtration rate, that's why we say GFR, will go down significantly because it's not a linear increase. So when you're going from moderate creatinine levels to slightly higher, that same interval has a much bigger impact in the drop in your calculated filtration rate versus if you're at a 1.2 to 1.4. You're kind of getting on the top end of this curve here, so drop-offs are not as significant. Regardless, that's going to look pretty significant in terms of your decrease in kidney function in this calculation. So as long as you know that you've been on creatine, which you should know, because unless someone's spiking in your drinks, it's a little grainy. You'll notice it. But it doesn't reflect anything bad. There was no actual kidney damage going on here. It is just an artifact of how we measure the stuff. If you're still worried, or if your PCP or whomever is still worried, have them check what's called a cystatin C. It's a different type of test, different product that is filtered through the kidneys, and so it will be independent of any sort of intake of creatine. But I've had both these myself where my liver enzymes suddenly spiked compared to previously, and my creatinine suddenly spiked compared to previously. In reality, it's because I had a good heavy lift and I've been taking creatine. All right, moving on to the next one. SHBG, or sex hormone binding globulin. It's a complicated one because it's influenced by a number of different things in the liver, as well as it has a very Goldilocks zone of when it's doing things well. And if it's too low, that's bad. If it's too high, that can be bad in terms of the amount of free testosterone you got circulating and its controlled estrogen, all that stuff. So you want to have it in kind of a sweet spot. There are times where elevations signify bad things, and there are times where elevations signify things are just going hunky-dory. As usual, let's go through the bads. In some cases, if you're in a hyperthyroid state, so your thyroid is producing too much activity here, so your T3 is too high, and all that stuff, that's going to stimulate a rise in your SHBG, about 2 to 3 times your baseline. Okay? Another case, liver diseases. This is all in the liver. So by having an impaired liver, you're going to impair the clearance and also the regulatory aspects of SHBG. Another one, if you have severe caloric restriction or anorexia, or in some cases, I think ketogenic diets might do this as well. You're going to drive up SHBG production here about 2 to 3 times the baseline again. So make sure that you're adequately nourished here. And a decently balanced diet. We're not going to get into the whether ketogenic diet is good or bad. I've got mixed feelings on that one. Definitely a great diet for certain cases. Difficult, can, if poorly done, cause problems. Maybe I'll do it another day. All right. High estrogen states. So, pregnancy, oral contraceptive use. If you're on estradiol patch for menopause, whatever, the high estrogen will increase your SHBG about 2 to 3 times the baseline again. So when in doubt, if something's going to raise it that shouldn't, it's probably going to be about 2 to 3 times. Now, when do we see this on the positive side of things? If you are doing a lot of endurance training, particularly recently you'll get a transient rise, but if you're chronically doing it, you're going to get this kind of steady rise. And this is about 10%-ish above baseline. So not crazy, but meaningful. Likely related to changes in insulin sensitivity and the liver regulates SHBG. And the inverse is true too. If you have insulin resistance, your SHBG is going to be low, and that has its own problems. We'll talk about that in a second. The last case, though, of a healthy situation boosting SHBG after significant weight loss, so like bariatric surgery. In those cases, you can get a rise of about 65% in about a month or so. And actually, there are some studies to suggest that the early rise in SHBG is going to predict a pretty sustained total weight loss from rapid improvements in insulin sensitivity and all that kind of stuff, which is a good prognostic factor for your overall outcomes from bariatric surgery. Now, the flip side is true too, where if you have infrequent testosterone dosing, that's going to push it down. If you have low estrogen, it's going to push it down. What SHBG is doing is regulating the amount of free testosterone to total testosterone. So the more SHBG and albumin, the more testosterone is bound up and not immediately available to be doing stuff. Free testosterone binds the receptors. However, you don't want it too low because you're going to have really volatile testosterone levels. Because if you have a lot of free testosterone that's not bound up like this, you're going to metabolize it and clear it faster because you don't have this protein protecting it from excretion and metabolism and everything. So you want this nice kind of sweet spot where, you know, in the normal range is between like 20 to 50, 60-ish. Somewhere in there is going to be a sweet spot that we can work with here, and it will change the way that I would prescribe TRT. If you have very low SHBG, I'm going to do a divided dose of subcutaneous injections because you want to essentially get a fairly reasonable fluctuation here between higher and lower testosterone. You don't want sustained high because that's where side effects come in. You don't want too low because it's going to be where you're not getting relief. But you've got to have a controlled area under the curve because that overexposure is where a lot of problems come from in terms of, excessive conversion to estrogen or excessive stimulation of red blood cell production, stuff like that. So if you give it a little bit of variation here because of this pulsatile several times a week injections, you can get the benefits here without having one solid rise here or sustained kind of lower levels to avoid the side effects kind of thing. On the flip side, if your levels are reasonable or higher, I might use something like an orally dissolving tablet, a troche there, because that's going to have the peaks and valleys blunted a little bit by the SHBG. And so you can take advantage of the way the troche works as a daily absorption to mirror the pulse of testosterone you might normally get if you didn't need TRT. To recap one point that I lightly touched on, it is surprising because someone who has insulin resistance and metabolic disease, they're going to have a lower total testosterone, but the relative ratio between the total to the free is going to actually be more in favor of the free, all else held equal, because that insulin resistance is going to lower SHBG. So more free testosterone relative to how much is total there. Whereas myself, I've actually had very, very high SHBG when my testosterone is high, not when I'm sleep deprived and exhausted from going to Sesame Place yesterday with my son. In those cases, on a good day, I might have a total testosterone 800 or 900, whatever, and SHBG to control it. So my free testosterone is not too high, not super physiologic, as we call it. In healthy cases, you might see a higher SHBG, and that's to keep that total testosterone from resulting in an enormously high free testosterone in an otherwise naturally regulating system. We can push this thing to the other end of the extreme if you're on exogenous, so external testosterone, and kind of violating that normal regulatory process here. But that's obviously not relevant in this conversation of surprise healthy abnormal labs. Cholesterol. I don't think it needs to be said that the debate around cholesterol is probably amongst the most contentious and long-standing debate in most areas of medicine. But in reality, all else held equal, it's the particles that matter. So when you look at just a normal testosterone panel, and actually one of my earliest videos was on the subject looking at my sister's labs, you'll see a surprisingly high total cholesterol, surprisingly high LDL cholesterol, and a high HDL cholesterol. What that's implying here is that you're doing a lot of trafficking of these particles because triglycerides are low and the LDL particles and HDL particles are carrying a lot of baggage, essentially. What you need to do, and people are finally starting to do this more often, is look at an ApoB, which is a count of the number of particles that are carrying LDL cholesterol and its cousins and whatnot, to see, are there a lot of particles in the bloodstream? The particles are what cause problems, not the cholesterol on them. So you look at the particle number and see that the level is low. That means there are fewer shots on goal for a particle to break through the artery wall and start causing plaques and all kinds of problems like that. There's some ongoing debate between whether the particle size matters. In most studies now, when you control for the actual ApoB, the actual particle number of all those guys, you're going to see that the size likely doesn't matter. But if it does, the bigger the better. Because big old beach balls are harder to break through a wall than little BBs. So in those cases, if you have equal particle numbers and the particle size is different, I'd err on the side of caution and say you probably want those things to be as big as possible. All right, high estrogen levels in men. So in this case, the obvious is true, where if you have high estrogen levels in a healthy guy, it's probably because they have high testosterone and you're getting a high conversion of testosterone to estrogen. So if you look at a high free testosterone, I roughly look for a ratio around 1 to 3-ish, give or take. So free testosterone, I'm going to drop the units at the end of this thing just so we can use regular numbers, not say nanograms per deciliter all the time. But a free testosterone somewhere in the realm of, 12, we'll say, might yield a healthy estradiol level, so it's the main estrogen, of roughly 40-ish, and that's okay. If you're on TRT and your free testosterone is bumping up on the 15, 20 area, it's reasonable to have an estradiol of 60. It's not a big deal. It's actually good for you. That's going to maintain healthy erectile function, healthy brain tissue, healthy heart, healthy pick an organ, basically. It's when you artificially suppress the estrogen down, there are studies that support this, that you actually get more metabolic issues, you get more weight gain, you get, worsening libido. I'm going to do a separate video where I discuss one of the most ridiculous cases of testosterone therapy I ever saw, in which case I had a patient who 6 weeks after stopping TRT still had a total testosterone of 900 because he was on, well, we'll get into a different day. The main point here is that estrogen is necessary for a lot of functions that you think that testosterone is doing the heavy lifting. In reality, when it comes to metabolic health and libido and brain health, all that stuff, without the estrogen, you lose all the benefit. With the testosterone, you lose some benefit too. But even in cases where someone's, bodybuilders are cutting for a show or something, and the old prevailing wisdom was, if you're having trouble, it's because your estrogen is too high. That's got to be low. That ain't the case. All you're going to do is make it harder to do that, and you're going to be cranky and no libido and feeling pretty blah about life during the whole time. So in reality, high estrogen because of high testosterone is an appropriate and healthy thing. You also might get transient raises after exercise in estrogen. So if you have if you're doing strenuous anaerobic exercises, so something along the lines of sprints or squats, something like that, the rise in testosterone, again, is going to create an equal rise in estradiol, give or take, percentage-wise, proportionally. If you're doing prolonged aerobic exercise, you also might get an acute boost in estradiol of your estrogen here, alongside testosterone. It might be even a little higher, actually, in some studies. This is a normal stress response. It's not an endocrine or hormonal issue. However, long-term, so chronic, you're doing this stuff regularly, aerobic exercise, it won't change your resting estrogen levels. It's going to keep everything nice and in range and appropriate here. Of course, there are unhealthy reasons to have high estrogen in men, higher body fat. We have the hormone aromatase in body fat. So as those levels increase, you're going to have higher conversion of testosterone and estrogen. That's going to cause that issue. Similarly, if you have higher SHBG, mentioned earlier, you're going to have higher estrogen levels too. because it's going to be bound up, and the free amount is what's going to stay static here. The flip side is also true. So in this scenario I'm about to describe, we see that higher estrogen in men is associated with maintained libido, even as testosterone goes down, but also healthier HDL and LDL levels and particle loss stuff also correlate with a modestly higher estradiol than you'd expect, or than you really think is ideal until you saw these numbers. So I've seen cases where a guy has, appreciably low total testosterone. They have all the low T symptoms except for the sexual ones are less prominent, and that's because of their estradiol being maintained at a healthy level, a healthy absolute level. Because in this case, you still want the ratio to be correct to have the full spectrum of benefits and minimize the risk of estrogen-related side effects like gynecomastia, so fresh tissue development, all that kind of stuff. BMI. This is one that many people have issues with for good reason, and that's because body mass index, if you look at the formula, all it's really taking into account here is height and weight, and that's determining your health status. Case in point, I've been overweight my entire life because I've always been fairly fit. So I've had a relatively higher muscle mass to what my frame would suggest. And because of that, at 190, 195, at 6 foot-ish, it's a BMI in the upper 20s, overweight. So every time I go to the doctor, I see the printout afterwards with the ICD-10 codes and it says overweight. And, I was brittle at that because I meant my insurance rates are going to go up because they're going to see this code and think it's a problem. Grinds my gears with insurance. Don't get me started on that one either. In reality, BMI needs to be adjusted to waist circumference. So that's the easiest way for me to be able to know, is it a meaningful elevation of BMI or not? So for a guy, if I'm meeting them on telehealth and I can't see them sitting down as well, I'd say, what's their pant size? If their waist is 32 and they're $195 like myself, that's fine. It means the visceral fat component, which actually really matters here, is quite low. On the flip side, someone who is, 180 or 175 at 6 foot, but their waist circumference is 40, that is a totally different picture. That is an unhealthy amount of visceral fat that's causing inflammation, insulin resistance, and all kinds of secondary issues. You're going to see that ALT to AST ratio we were mentioning earlier. In those cases, BMI is underplaying the magnitude of metabolic issues here. So that's why it's really important to understand when these abnormalities are actually meaningful versus something to explain and hopefully doesn't get documented and ruin your insurance rates again. All right, so to recap. Rising batteries dying, perfect. Number one, if your liver enzymes are elevated but equally, modestly, and you had a workout before that, do a retest. It's probably normal and reasonable because your muscles got banged up during the exercise. If your creatinine is higher, but it's because you've been on creatine for more than a couple months, ask them to do a cystatin C or just do a little mental fudge factor here, subtracting out 0.2 from your creatinine level and seeing if that actually is a meaningful issue with your EGFR afterwards. SHBG. You don't really react to this one. You just look at your free testosterone and see if it's low based on that. If it's very high and you have some other subtle signs of liver issues, maybe your enzymes are elevated, it's not from exercise, dig a little deeper. See if something else is going on there. If you're having signs of thyroid issues, get your thyroid checked. Cholesterol. Remember, ApoB is one of the most important things I look for. I basically had a cholesterol panel. My eyes go to two things: triglycerides and ApoB. If trigs are low, ApoB is low. I don't care what the rest of it says, really. Yes, there's some more nuance to it than that. I'm going to say that for advanced lipidologists, cardiologists who are parsing out why a family history is the way it is despite healthier numbers. But in general, if you've got fairly high HDL-C, typically protective, not always, typically a good thing, low ApoB, low triglycerides, we'll move on to a different part of the conversation because that is obviously not an issue. However, if your doctor's only running an LDL-C or the panel doesn't include ApoB, and they're again marking you down with hyperlipidemia and overweight and elevated creatinine, you're going to get dinged on your insurance for something that is actually a reflection of good health. So make sure it's clarified and coded correctly if you can, or at least find someone who actually pays attention to that kind of stuff. Some doctors don't have the time to get into the nuance of these things when they're seeing appointments 8 minutes apart because they're relying on insurance to pay the bills. See my concierge video for more information. High estrogen, not a problem. Does a lot of good things, as long as it's reasonable and proportionate to your testosterone levels. So When you control the units and get them in the same scale, you want your estradiol somewhere around 3 times-ish to what your free testosterone is. And this way you know that it is appropriate. So when you have high free testosterone, you'd expect a high estradiol. If you're not having symptoms of nipple tenderness, sensitivity, breast development, emotional lability, those kinds of things, probably not an issue. Do not let someone give you an aromatase inhibitor because they're doing the right thing of lowering your estrogen levels. All you're going to do is gain weight, feel crappy, hot flashes. You're going to go through menopause if you take one of these just to treat a number. Finally, BMI. Remember, lower BMIs, not always better. Higher BMIs obviously need to be in certain situations. But if your BMI is upper 20s, low body fat, clearly it's not a problem. Use waist circumference to quickly elucidate where it's relevant and where it's not. Please like and subscribe. It helps us a ton. It lets me spend some more time on this stuff. I love doing these videos. I'd like to do more. And with that kind of feedback, I can justify it to the rest of the team. Thanks for watching.